So the next thing you want to think about is maintaining the blood pressure of a trauma patient. As you already know, inadequate blood pressure can lead to decreased tissue perfusion, hypoxia or anoxia, so their inability for their tissues to actually get oxygen. It causes problems with anaerobic tissue metabolism, lactic acid production, and it can cause an acid-base imbalance, which can throw the entire body off. So this is why we monitor BP. And again, remember, your goal is for your MAP to be greater than 60 millimeters of mercury. You can do things to administer fluids, crystalloid versus colloid, which we'll discuss, and give drugs such as dopamine, dopamine to help maintain blood pressure. Wrong way, sorry. So first thing to think about is crystalloid fluid administration. You can be thinking about fluid rates of about 10 to 20 mils per kg per hour. We use 10 for just our general surgeries, but if they need more, up to 20, you could be using 9% saline, 0.9% saline, LRS, Plasma-Lyte, Normasol. You may need to bolus fluids. These are some rates which you can do that. Dogs, 20 to 40 mils per kg over 15 minutes, and cats, 10 to 20 over 15 minutes. And then you would probably drop them back to a 10 mils per kg per hour rate. Now, keep in mind, crystalloids are gone from the intravascular space by 2 hours, so they go from the veins or the vasculature into the tissues within 2 hours. So they're good for a bump, and then they'll go somewhere else. Colloids is what you try if their blood pressure is not being maintained by crystalloids, or if their total protein is less than 3.5. These stay in the vascular space longer, so they'll have a longer effect at maintaining the blood pressure. They do this by increasing the colloidal osmotic pressure. Different examples of colloids are hetastarch, dextrin, 10% pentastarch, plasma, and whole blood. These you'll use in much smaller volumes, so dogs 10 to 20 mils per kg, and cats 5 to 10 mils per kg as a total volume. You do have to be careful that you don't cause fluid overload. That is too much fluid in too short a period of time. Some signs of this would be crackles or wheezes on the lung. The lung tissue will get filled with fluid. You can also have nasal discharge, bulging eyes just due to too much fluid in the tissues, increased respiratory effort, coughing, vomiting, diarrhea, restlessness, increased output. Of course, you may not see these in the anesthetized patient, but you may start hearing the crackles or wheezes on lung auscultation. So now we're going to talk about patients with different underlying issues, things such as cardiovascular disease. These could be pre-existing conditions such as anemia, shock, cardiomyopathy, congestive heart failure, or heartworm disease. And then these can also cause problematic anesthetic conditions. So you're more likely to see hypoxia, hypercapnia, electrolyte imbalances, especially potassium, sodium, calcium, hypothermia, vagal stimulation, and anesthetic overdose. A way to try to work around this is make sure you do pre-anesthetic evaluations, such as your physical exam and blood work. Most likely, you'll see bradycardia is the most common cardiac abnormality during anesthesia, often caused by drugs. And it's worth knowing how your low heart rate affects blood pressure. So here it shows you how arterial blood pressure equals the cardiac output times the systemic vascular resistance, and also E equals heart rate times stroke volume. So memorize these equations. But you can see that if your blood pressure is low, that would directly lower your cardiac output and your vascular resistance. Anesthetic drugs may also decrease heart rate, the force of the actual contraction of the heart, and the blood return to the heart, which is also known as preload, specifically alpha-2s, opioids, and occasionally phenodiazines. So when you see bradycardia, sometimes all you need to do is turn down your anesthetic gas just to reduce it a little bit. Maybe they're just a little too deep at this time and they'll come right back up. Make sure you check for hypothermia, because if they're cold, you may start having problems. Now, what can you treat with what drugs? So if you want to increase vagal tone, atropine or glycopyrrolate. If you're trying to increase parasympathetic tone, catecholamines, dopamine. And if the heart rate is 50% of normal or blood pressure is low, you can give them epinephrine. Also, cardiovascular disease could show itself in forms of arrhythmias. Causes for arrhythmias could be anoxia or hypercarbia, poor perfusion, acid-base imbalance, and damaged myocardial tissue. Also, so you have to make sure you are listening for arrhythmias by ausculting the heart, and if you have it, an ECG monitor. Now remember, when you listen to the heart, you want to listen to both sides. Also, sometimes both, even though you may not hear something before you medicate, listen again after you pre-med, you may start hearing something, and definitely once they're under anesthesia. So, these are some important ECG rhythms that you must be able to identify. Premature ventricular contractions, atrial fibrillation, ventricular fibrillation, first and second degree heart block, ventricular tachyarrhythmias, and a sinus arrest with escape beats. So this is your normal sinus rhythm. This is ventricular tachycardia. It's just big, crazy waves. But you will see they're somewhat rhythmic. Here is your first degree AV block. You look at your pattern. You'll see things get delayed. They don't get to go all the way through. Here's a sinus arrhythmia. So that's when the heartbeat slows and increases as they breathe. Here's a second degree AV block. So if you look in the middle right there, you'll see that it doesn't even have a QRS complex. And this is ventricular fibrillation. And then VPCs, or ventricular premature complexes. This means there's a ventricular contraction before the whole PQRST wave series has started. And it looks like it's about to go into some ventricular tachycardia. This is a sinus arrest with escape beats. So you can see a P wave happens and nothing follows it. Or you may have a broad QRS complex but no P wave. This can happen at a rate of 20 to 40 beats per minute. So it's not like a true heartbeat. It's just these random beats happening. If you do identify a rhythm or an arrhythmia, you need to make sure you let the veterinarian know. You may be giving lidocaine for dogs or beta blockers for cats. You may need to switch to a CRI. During drug prep, you may be asked to put pressure on the eyeballs or massage the carotid sinus. This helps to increase parasympathetic stimulation. So while somebody's grabbing drugs, you can start doing those things. And if you have AV heart block, you want to use atropine. Pulmonary disease often goes hand in hand with cardiovascular disease. It may be useful, again, diuretics such as Lasix to reduce pulmonary edema, so fluid that's actually in the lung tissue. Make sure you stabilize the patient first. Pre-oxygenate, induce as quickly as possible, so that way they're on oxygen, possibly even on a ventilator. Avoid drugs that depress the myocardium or exacerbate arrhythmias, such as alpha-2s or halothane, so you may have to rethink your regular protocol depending on what it is. And be careful because of the risk of overhydration, especially if they already have pulmonary edema or pulmonary disease. Patients that already have respiratory disease, so these aren't necessarily caused by issues, or they may be, pleural effusion, so free fluid in the thoracic cavity, diaphragmatic hernia, pneumothorax, contusions, pneumonia, tracheal collapse, or edema. Problems, obviously, poor oxygenation. This will decrease their tidal volume and respiratory rate. It can develop hypercapnia. Most likely you'll notice while they're under anesthesia tachypnea, dyspnea, and cyanosis. So you're remembering to check those mucous membranes. Ideally, you want to try to delay anesthesia until the respiratory function has already improved. So, is there anything you can do instead of putting these animals under general, such as using a local block on manual restraint? You want to be able to evaluate how well the patient can move air in and out of the lungs. Usually you have to listen to their lungs, also watch their effort, evaluate their oxygen carrying capacity. You could do this by their packed cell volume, make sure they're not anemic, using a pulse ox, or if you have the capability of blood gas, so that's not usually an option. Thoracocentesis may be necessary, which we already discussed. Pre-oxygenate, 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 and potentially, once they're under, using assisted ventilation to help make sure that they get their full lung capacity and are taking deep, full breaths. So some things to look for in patients that have respiratory disease or are even developing it during anesthesia. Biggest things are dyspnea, so difficulty breathing, or cyanosis. There's a nice image there on the right of a cat with a very blue tongue and blue gums. Assess their respiratory character, how they're breathing, volume, how much they're able to inhale. Are they taking tiny little shallow breaths or big, slow, deep ones? How deep is their anesthesia? Is their breathing associated with pain? So don't forget, the respiratory rate can increase when they're painful. Is the ET tube placed correctly, or is it possibly occluded? Make sure it's not in the stomach. That's not just in one bronchi, or that there isn't a big phlegm wad or something in it, or it's not pushed up against the edge of the trachea. Oxygen saturation, and then their end-tidal CO2. So once you've determined the cause, you can try some intermittent positive pressure ventilation, okay? With the vaporizer turned down. You don't necessarily want to be flooding them with ISO every time you give them a breath, especially if you're trying to get them oxygen, not ISO. And remember, adequate pressures are important, not to exceed that 20 centimeters of H2O, otherwise you could damage their lungs. If necessary, you may need to re-intubate. You can take radiographs to see what's going on, and potentially a thoracocentesis, both to diagnose fluid or air, and it will also be therapeutic to remove any excess fluid or air. So diaphragmatic hernias, these require surgical repair. It's tricky. You have to oxygenate first to try to get as much oxygen into their body. You want to avoid head down positions. That puts way too much pressure. The intestinal contents, abdominal contents will push up against the diaphragm. Again, induce rapidly. You will definitely be using a ventilator or hand ventilating them because they don't have the ability to take full breaths. Monitor them for cyanosis. And once you recover them, you have to continue monitoring them. They may need prolonged oxygen, whether it's in a cage, flow by, etc. And often pneumothorax is a common sequela after surgery because air has gotten into the chest cavity through the hernia. So patients with hepatic disease, don't forget the liver has a lot to do with drug metabolism, clotting factors, serum proteins, carbohydrate metabolism. This can also secondarily cause problems in dehydration, icterus. They'll be thin, anemic. You have to be very careful about pre-meds. Most require liver metabolism. Acepromazine may last particularly long in their system, so you may have to get rid of them completely. Use reversible agents whenever possible, so that way if they're having problems, or you can wake them up as quickly as possible once you're finished. Avoid ketamine and diazepam. And if nothing else, just use straight propofol for pre-med induction and isoflurane. Renal disease, big problem is dehydration and electrolyte disturbances, especially hyperkalemia or increased what? Acid-base imbalance can cause a metabolic acidosis. Anesthesia decreases renal blood flow, and if they already have bad renal function, this can compromise their kidneys even more. And you have to be careful about injectable NSAIDs, as these may also reduce perfusion to the kidneys. There's some renal function tests so that you know how things are working. Do not deprive the patient of water, rehydrate, and reduce certain drug doses, especially ACE, xylazine, diazepam, ketamine, and barbiturates.